Hello. Are you
Hello.
guys okay? So, okay, let me just share my screen. Okay. So yesterday we discussed ascending tracks, if you guys remember, right? And we discussed that ascending tracks, they are basically going to take your sensory sensations from your peripheral tissues into your brain. Your brain then is going to compare it with the past experiences, and then it's going to generate a motor response, right? Hello. We discussed dorsal column, medial lemniscal tract. We discussed anterior lateral tract. Today we are going to discuss the descending tract. So can you guys just tell me that descending tract is motor in nature or it's a sensory?
Motor.
Motor.
Okay, perfect. It's going to generate a motor response. Okay, can you guys just tell me that the upper motor neuron is going to synapse in the neuron of anterior horn or posterior horn?
The
Anterior horn.
anterior as its motor.
Yes, perfect. Anterior horn, because anterior horn you have like lower motor neurons of your motor nerves, right? Okay. So before discussing that how does the motor response get initiated, you should know certain area within the cortex, right? Okay. Remember that inside the cortex, basically your cortex is divided by a sulcus, which is known as central sulcus, right? For example, let me just draw your cortex. For example, this is your cortex, your cerebrum. Okay. And for example, if you have an individual like that, okay, and like it's his brain, right? So you have a central sulcus, a big kind of sulcus, which is going to, divide your cerebrum in between, right? And this is basically called as this dividing sulcus or fissure kind of structure is known as central sulcus, right? Central sulcus. The area posterior to central sulcus is sensory in nature, right? It's sensory. As we discussed that your ascending tracts are going to bring information where to your sensory, so to your sensory area, right? Just behind the central sulcus. Is that clear? So it's responsible. It's an area where all of the sensations are ultimately going to come. Is that clear? Hello?
Yes.
Yes.
And this area is also known as post-central gyrus, right? Hello?
Yes.
Okay, so this area is also known as post central gyrus. Like this is your central sulcus or central gyrus, right? So behind the central gyrus, you have an area where all of the sensory information is going to relay. That's known as post central gyrus or sensory cortex. Is that clear? Okay. Anterior to this central sulcus, you have an area which is responsible for generating your motor response, right? So you have an area, first of all, right in front of this central sulcus. This area is known as primary, yes, primary
Motor.
motor cortex, right? Is that clear?
Yes.
Okay. Right in front of this primary motor cortex, you have an area here on the top, which is known as supplementary motor cortex. Is that clear? And just like in front of primary motor cortex and beneath supplementary motor cortex, you have an area which is known as premotor cortex. Premotor cortex. Is that clear? All of these three areas are responsible for generating a motor response. Is that clear? Okay, let me just revise it again. So you have a gyrus or a central gyrus or a central sulcus. Behind the central sulcus, you have an area for all of the sensory information. Like all of the sensory information are going to come. It's going to rely in post central gyrus. Then you have pre-central gyrus, like in front of central gyrus. All of that area is responsible for your motor impulses, generation of your motor impulses. Right in front of central sulcus, you have an area which is known as primary motor cortex. Just in front of that, a little bit superiorly, you have an area which is known as supplementary motor cortex. And just beneath that, you have premotor cortex. Is that clear?
Yes.
Okay. Now the question arises that what is the function of primary motor cortex? What is the function of supplementary motor cortex? and what's the function of premotor cortex, right? So remember, in the supplementary motor cortex, if let's suppose if I just take an electrical probe and stimulate an area in primary motor cortex, right? So what will happen as a result of that, right? In order to look for the function of respective areas, there are two methods for that. Either you can stimulate it electrically, if you have electrical, like probes, and you stimulate a specific area, so you'll be seeing some motion. Is that clear? Because every specific area is responsible for specific group of muscles. You know the concept of homunculus, right? We'll be discussing that as well.
Yes.
Okay, so for example, if I just take an electrical probe and stimulates different areas within the primary motor cortex, so what happens? We will be seeing only movement of a group of muscles, a group of muscles movement, but that movement is going to be, yes, what do you guys think? It would be purposeful movement or not non-purposeful movement? Anyone? Hello?
Non-purposeful.
Perfect. It would be non-purposeful movement, right? Only a group of muscles is going to move. Like, for example, let's suppose if I just move, electrically stimulate certain area within the primary motor cortex. So what happens? Let's suppose only my fingers would move, right? But if I'm electrically stimulating certain area within the premotor cortex, we'll be seeing movement, but that would be purposeful movement. Is that clear? Like, for example, if I just stimulate an area within the premotor cortex, so what happens? Your hand is going to, like move, and you might even start walking, right? Because that's a purposeful movement. Is that clear?
Yes, sir.
So premotor cortex is responsible for purposeful movement, while primary motor cortex is important, like it would just stimulate a group of muscles. So how to have a purposeful movement? What happens that premotor cortex will be in communication with your primary motor cortex. What would it do? It would stimulate those areas which I want for my purposeful movement to move. Is that clear? Hello?
Yes.
But this generation of movement is a little bit complex. Why? Because your premotor cortex by itself cannot undergo a purposeful movement. It is in communication with basal ganglia, right? Basal ganglia, we'll be discussing that. And basal ganglia in turn is going to, come back to your cortex. And as a result of that, you are going to have purposeful movement. What is the idea of basal ganglia? Let me just tell you a little bit, right? For example, let's suppose if I want to write, right? If I want to write something on my page, right? Let's suppose I'm writing now, right? So what happens that during writing, you guys can see my flexor muscles of fingers are activated, while extensor muscles of my fingers, they are inhibited, right?
Yes.
Is that clear? It means during a fine movement or a purposeful movement, it's not that you are going to stimulate all of the muscles. You are going to stimulate certain muscles, but at the same time, you have to inhibit the opposite muscles, right? Is that clear?
Yes, sir.
For fine movements. So basal ganglia is important for that, because we'll be discussing certain pathways, direct pathway and indirect pathway, right? So one pathway is stimulatory while other is inhibitory. So the direct pathway, for example, it would keep on stimulating your muscles, while the indirect would keep on the opposite group of muscle to be inhibited at the same time in order to perform fine movement. Is that clear?
Yes,
Hello?
sir.
Okay, perfect, right? So basal ganglia is also important for that. So your premotor cortex, it will just send the like response. For example, if all of the sensory information come here, what happens? It would just compare it with the past experiences. Then it have to generate a purposeful movement. So for that, your premotor cortex would just send signal to your basal ganglia. Basal ganglia would again, fine tune it, and as a result of that, a specific group of muscles would be, like stimulated, while at the same time, the opposite group of muscles are going to be inhibited. Is that clear?
Yes, sir.
Okay, perfect.
Excuse me, sir.
Yes, please.
I have a question. So,
Yes, please.
what's the role of the primary motor cortex?
What's the role of?
Primary motor cortex.
Okay, that's a good question. As I already told you that premotor cortex is responsible for purposeful movement, right? And primary motor cortex is responsible for a group of muscles movement, right? So for purposeful movement, like simply you can think of, it's premotor cortex is a mini brain, right? It takes decisions by its own. It takes decisions which are wise decisions, right? Which are purposeful decisions. Is that clear?
Yes.
While primary motor cortex do not have brain, it only like stimulate a group of muscles. So for a fine movement, you need brain plus primary motor cortex, right? This brain will just tell the primary motor cortex, just stimulate this one, stop this one, stimulate this, stop this, right?
So the premotor cortex is gonna send signals to the primary motor cortex,
Yes.
and that's how the flexors and the extensors in our hands are gonna work
Yes,
when we
yes,
write.
that's the like primary motor cortex. Like whenever you stimulate primary motor cortex, only a group of muscles is going to be like start moving, right? So it means that for the premotor cortex, in order to undergo purposeful activity, what would it do? It must be in communication with your primary motor cortex to stimulate certain group of muscles and inhibit other group of muscles through the help of basal ganglia. Is that clear?
Yes, sir.
Okay. Then we have supplementary motor cortex. For the supplementary motor cortex, you guys should just keep in mind that it is important, or it is responsible for some primitive movements. What do you mean by primitive movements? Like movement of your axial skeleton, movement of your shoulder, movement of your hip joints. Like you guys can see the primitive movement of monkeys. Whenever the monkeys are excited, how do they move? They like keep on moving their shoulders and like start jumping, right? So these muscles are considered like primary muscles or primitive muscles, right? So in order to undergo your axial movement, supplementary motor cortex is important for that. Is that clear? Hello?
Yes, clear.
Yes, sir.
Okay. Okay.
Yes.
So we have primary motor cortex. We discussed it's present superior lateral. In front, in front of central sulcus. We discuss premotor cortex, which is like like important for purposeful movement. Supplementary motor cortex, which is important for some primitive movements, for example, movement of your trunk and hip. Is that clear? Okay. If we zoom in the premotor cortex further, there are certain structures present within the premotor cortex as well, right? And what are those structures? You have, like, for example, let me zoom in this picture, right? This is your premotor cortex. So below we have an area which is known as Broca's area, right? Then we have an area which is known as, yes, frontal eye field. Frontal eye field. Then we have an area for neck movement, right? And then we have an area for hand movement. How do we know that? We already know that. For example, if I am just, okay, how do I know that this area is Broca's area, which is important for your phonation? You have frontal eye field, which is important for your, moving, like for your lateral gaze, right? We have an area which is important for the neck muscles. We already know that. For example, if I am just electrically stimulating this area, so what happens? A person would start speaking, right? So that's why I know that this area is important for speaking, for phonation, for creating sounds. So let me just name it as Broca's area. Is that clear? So this imaginary picture which I have drawn, that specific areas are responsible for specific movement, it is known as homunculus, right? Is that clear? So homunculus is basically an imaginary picture which indicates that specific area is responsible for specific motor movement. Is that clear? Hello?
Yes.
Yes.
Okay. So what's the significance of Broca's area? For example, if I'm electrically stimulating the Broca's area, so it's important for phonation, right? Is that clear?
Yes.
Yes, sir.
And you guys know Broca's, okay, in most of the individuals, Broca's area is present in the dominant hemisphere. Is it right or left? What do you guys think in most of the individuals? It will be
Left.
present on the right side or left side?
Right.
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 Left.
Right or left?
Left, left
Left
is
side.
Left, because most of the
Dominant
individuals
one.
are right-handed. So it means that their contralateral hemisphere is going to be the dominated one, right?
Mhm.
The left hemisphere. Most of the individuals are left dominant, right?
Yes.
Okay, perfect. So whenever we have damage to the Broca's area, what happens? Okay, so this individual can just speak, like his words would make sense, but the wordings which he's producing as Broca's area is only responsible for phonation. So what happens? The words would be broken words, right? Broken words. He will be like, speaking in such a way that he cannot, like speak fluently. But his words or whatever he is speaking, it would make sense, right? So there is the comprehension is present, but the words would be broken. You have a U-word MCQ on that. Is that clear?
Yes.
Like the words would be meaningful, right? It would just make sense, but the words would be broken, like how are you, like that. Okay, is that clear?
Yes.
Sir, can you please repeat that? I did not get it.
Okay, so Broca's areas was responsible for like only creating sounds, right? Phonation, speaking, right?
Yes.
If we have lesion to the Broca's areas, what happens? For example, if okay, what is your name, by the way?
So Minahil.
Minahil. Okay, so Minahil, like this individual, for example, if someone is having Broca's area, so he'll be communicate in a way like, how are you, Minahil? Still, his words are making sense. He want to ask you that how are you, right? But his
Yes.
words would be broken.
Yeah.
So it would be difficult for him to speak fluently.
Okay.
While we have an area which is known as Wernicke's area, right? If we have Wernicke's aphasia, what happens? His words would be fluent, but his words won't be making sense. You have a U-word MCQ on that, right?
Okay. Yeah.
Like he'll be just his words won't make any sense. He would be like Minahil, I am, you assembly and this, and you would say what is he trying to say, right? Still he will be like speaking fluently, right? So this is the main thing. You have a U-word MCQ on that. If you have meaningful wordings with broken words, there is lesion to Broca's area. If you have fluent like like wordings or fluent language without any comprehension or without any meaning, it means you have problems with your Wernicke's area. Is that clear?
Yes, sir. Thank you.
Okay, perfect. Then we have another, on the homunculus, we have another field which is known as frontal eye field. What is frontal eye field? Do anyone knows?
I think it is associated with the primary eye movement.
Okay, primary eye movement. Okay, for example, if I have your right side and your left side, right?
Mhm.
Let's suppose if I am just stimulating the right-sided frontal eye field, so what do you think will happen to your eyes? Where would it look?
Laterally.
Yes.
Lateral
It's
gaze
less-
will be disturbed.
Opposite, right?
Yes.
Okay. Remember, whenever, okay, for example, if I'm just stimulating the frontal eye field of the right side, it means that the eyes would just look opposite. Remember that, right? This is basically known as contralateral gaze, right?
Yeah.
Hello? It's contralateral gaze, right?
Yes, right.
Let's suppose if I'm stimulating the frontal eye field of the left hemisphere, what would happen? Eyes would just look opposite again, right? And if I'm stimulating both of them all at once, eyes are going to look forward, right? In front. Is that clear?
Okay, yes.
Okay. An important point, whenever I'm stimulating the right-sided Broca's areas, or if I'm irritating, right? Like for example, if I'm irritating it with a probe, let's suppose, right? So it means that eyes would look to the opposite side, right? But if we have lesion of frontal eye field, if you do not have frontal eye field, it's completely damaged, eyes would look towards the damaged frontal eye field. Is that clear?
Yes.
So- Okay. Okay, let me just give you an example. For example, if I have an individual, right? Okay, and this is like, this is me, right? And let's suppose if I'm just irritating him, right? I'm just poking him. What happens? He would just look away, right?
Mm-hmm.
Okay, if I just slaps him, he will just look towards me. That what are you doing,
Yes.
right? So only irritation, he'll be like, sad, looking away. But whenever I slap him with the lesion, what happens? Eyes would look towards the lesion. Is that clear?
Ah, okay.
Yes or no?
Yes, yes, yes.
Right? So note it down. Whenever you are stimulating or irritating your frontal eye fields, your eyes are going to look away. But whenever you have a lot of your MCQ on that, right? Whenever you have lesion whenever you have lesion of your frontal eye field, eyes are going to look towards the lesion. Is that clear?
Yes.
Yes,
Okay,
sir.
perfect. Right? So these are the two areas which are very important. You guys should know that. Okay? Okay.
Okay.
Then we have our primary motor cortex, right? So on the primary motor cortex still we have a homunculus, right? We know that imaginary picture or structure which indicates different areas, right? So you have a UWorld MCQ on Broca's area, I have already discussed. You have UWorld MCQ on frontal eye field, you already discussed that. Let's discuss homunculus of primary motor cortex, right? So for example, let me just draw the, yes, please.
Injury to Broca's can lead to aphasia.
Yes, it can lead to aphasia, and this individual, as we already discussed, he would be having broken words, right? The words would make sense, but still the words are going to be broken. He cannot speak fluently.
Wernicke's injuries cannot lead to aphasia. Only Broca's injuries can lead to aphasia.
Wernicke can lead to aphasia, but in that case, he will be speaking fluently, but his words won't make sense. Is that clear?
Yes.
One is Wernicke aphasia and Broca's aphasia. Both of them are a little bit different from one another. Is that clear? Okay. Then let's discuss. Okay, so we discussed the homunculus of premotor cortex. Let's discuss the homunculus of primary motor cortex, right? So, for example, if this is your primary motor cortex, let's suppose. So, the homunculus is in the way that your medial and superior aspect of your primary motor cortex is responsible for feet movement, right? And then you have your knees, your feet, your knees, and then your hands, right? Your upper limb. Okay, so these are your feet, your knee, and along with that, also some bladder functions, right?
Upside down.
Right? Like upside down. Okay, then you have your head and neck function. Okay, this is head and neck. Sorry for the pictures. This is your head and neck function. And in the end, you have an area for pharynx and larynx, right? Is that clear? Hello?
Yes, sir.
Okay, let me just show you in another aspect. For example, if this is your brain or cerebral hemispheres, right? So what happens here is that, let me draw the homunculus. So here, this area is basically responsible for your leg movement. This area is basically responsible for your feet and leg movement, right? And if you are just coming out like that, so it means that this area is responsible for your knee movement, like upside down, right? And as you come just laterally, you're going to see an area which is important for, okay, which causes hand movements, right? And in the end, for your head and neck, okay, these are the eyes and the lips and head and neck. And in the end, you have an area which is responsible for pharynx and larynx movement. Is that clear? This is the homunculus you guys should just keep in mind. Is that clear?
Yes.
Yes, sir.
Okay. So we'll be discussing a lot of questions. You have a lot of questions in UWorld as well. There are different blood supplies, right? Like for example, this area of brain, today we're also going to discuss blood supply as well, because you have a lot of MCQs, but here I want to tell you the significance, right? So you have 4 or 5 MCQs in UWorld if you know the homunculus. Okay, so this area of your brain is basically supplied by anterior
Cerebral artery.
cerebral artery, right? I'll be just discussing in blood supply, don't worry about that, right? And this area is basically supplied by middle cerebral artery, which comes in the lateral sulcus and supply these areas, right? So in the UWorld MCQ, for example, if we have an individual, he cannot walk, he have urinary incontinence because the bladder functions, and incontinence is also, you know, like this area, the superior and the medial aspect of your cerebrum is responsible for that. Is that clear?
Yes.
Hello? So if you have an individual, he cannot walk, he have urinary incontinence. So what do you think, which artery is affected?
Anterior
If this
cerebral.
individual is having stroke, perfect, anterior cerebral, right? If we have an individual, there is problems in his head and neck, he cannot move hands, right? He cannot, you know, like undergo the normal, you know, like a muscle contraction in pharynx and larynx. So what do you think, which artery, for example, if it's a condition of stroke, What do you think? Which artery is compromised?
MCA, middle cerebral artery will be affected.
Middle
Middle.
cerebral.
Cerebral artery.
So you have these two U word MCQ. You are going to see it, right? Is that clear?
Yes.
Yes, sir.
Okay. So let me just give you a summary of what we discussed, and then we'll be discussing our descending tracts. So we discussed we have central sulcus or central gyrus. Behind or posterior to the central sulcus, you have an area which is known as pre. Yes, what's the name of that? Pre or post? Post central gyrus, right? Post central gyrus. All of the sensory information are going to relay here. Which sensory information we already discussed? Those which are coming from your ascending tracts, your DCML and anterior lateral tract. Is that clear?
Yes.
What would happen that these sensory information are going to be compared with the past experience, and your brain is going to decide to initiate a motor response. For that, we have primary motor cortex, which is responsible for a group of movement muscles, unpurposeful, right? Then you have premotor cortex, which is responsible for purposeful movement. But for that, it have to communicate with the basal ganglia. The direct and indirect pathways of basal ganglia are going to come into play. Why? Because in a purposeful movement, we want some group of muscles to be stimulated, while at the same time, we need some group of muscles which must be inhibited. If I want to undergo a fine movement, is that clear?
Yes.
Then we discuss supplementary motor cortex, which is a little bit above your premotor cortex. It is responsible for primitive movement, monkey kind of movement, like hip movement and axial skeletal movement. Is that clear?
Yes.
We discuss homunculus. What is homunculus? It's an imaginary picture which basically, we have drawn, which indicates that this specific area is responsible for this movement. For example, Broca's area for phonation, frontal eye field for contralateral gaze, neck, head and neck, just, it isn't quite significant, but it's going to, have these areas are going to have motor innervation or upper motor neuron, which is responsible for your neck muscles and head muscles. Simple, right? Okay. Then we discuss Broca's area. If we have problems or lesion of Broca's area, person cannot speak, although his words would just make sense, right? With broken words. Broca's for broken words. Then we discuss frontal eye field. If you stimulates or irritates the right, eyes would look contralaterally towards the left. But if you lesion it, eyes would look towards the lesion, right? Is that clear? Then we
Yes.
discuss homunculus of primary motor cortex. We discussed that in the medial and superior aspect, you have the homunculus or the area for walking, for urinary, for the bladder. You have for the knee, and as we are just coming laterally, we have homunculus for hands and head and neck. Is that clear? So different arteries basically supply these different locations. So you have a UWorld MCQs on that. We already discussed. Is that clear?
Yes.
Yes, sir.
Okay. So now let's discuss corticospinal tracts. What are corticospinal tract? The descending tracts comes from the cortex towards the spinal cord. So let me just name it as corticospinal tract. Is that clear?
Yes.
Okay, perfect. So what happens that in corticospinal tract, remember, 30% of the fibers would just come from primary motor area, as we discussed. 30% of the fiber comes from your premotor area, as we discussed what is premotor area, plus supplementary motor area. Is that clear?
Yes.
Okay, and the remaining 40% of the fibers comes from sensory cortex, remember, right? We need that sensory component. Why? Because based on these sensory signals, we are going to initiate a motor response. Does that make sense?
Yes.
Yes.
Okay, perfect. So what happens that all of these fibers, although, okay, you also have like a big cells, which are known as cells of Betz, remember, right? Cells of Betz, which are present in, the cortex has basically 6 layers, right? So within the 5th layer, you have a big cells, which are known as cells of Betz. From those cells, we also have some fibers coming and joining all of these fibers. Is that clear?
Mm-hmm.
Hello? Like
Yes.
these, okay,
No,
so those fibers are
come
highly myelinated.
Can you please explain again?
Please. Thank you.
Okay, so we were discussing corticospinal tracts, right? Corticospinal tracts are also your motor tracts, right? For example, if I want to initiate a motor response, we have a descending or corticospinal tracts for that, right? Hello?
Yes, sir.
Okay. So, okay, so 30% of these fibers from, or like the fibers in corticospinal tract, 30% of the fibers are going to arise from primary motor area, primary motor cortex, this part, right? 30% of the fibers would arise from both of these parts like that, right? And 40% of fibers would come from sensory area. And in the motor cortex, okay, in the cortex, we have 5 layers. In the 5th layer, you have a big kind of cells. Those are known as cells of beds. You only have to remember that. Some of the fibers are going to come from that. And all of them will collectively form descending tract, right? Now we will be discussing the path of descending tract. Is that clear?
Yes.
Hello?
Yes, sir.
Yes, sir.
Okay, so let me draw the picture, and it would be like better to draw picture of that. Okay, so for example, this is your brain. Okay. Okay, so we discussed that fibers are going to come from the cells of bats, 30% from the primary motor cortex, 34% from the, we discussed that supplementary motor cortex and premotor cortex, they are going to come like that. And once they are just coming down, we know that we have a lentiform nucleus. We'll be discussing that in basal ganglia, and we have our internal capsule. Did you guys remember? Yesterday we discussed internal capsule, right?
Yes.
Yes.
So internal capsule, okay, on the same side here, you are going to have a lentiform nucleus. We have, okay, here we have thalamus, right? We also discussed thalamus as well, right? And again, we have our internal capsule. So these fibers are going to pass through the posterior limb of internal capsule. Remember, posterior limb of internal capsule, and they are going to come down like that, right? Is that clear?
Yes.
Okay, here they are going to form the crus cerebri. You know that the big like pillars which are attaching your brain stem with your cerebrum. That is basically known as crus cerebri, and all of these fibers are going to come through that, right? Remember, we discussed yesterday, if you guys remember, that all of the sensory information from the ascending tracts were going through posterior limb. Remember, like here they are in a compacted form, right? It have formed a limb, posterior limb, right, of internal capsule. We discussed it, right?
Yes, sir.
And here we also discussed that a motor tracts are also going to pass, or they are also going to move through the posterior limb, right? So for example, if you have a U-World question, you have a U-World question in which we have an individual, both his sensory and motor responses are lost.
Yeah.
He can't sense anything. He can't generate a motor response. What do you think, which structure is affected?
It could be the posterior limb, as both of them go through it.
Perfect. So posterior limb of your posterior limb of internal capsule. Is
Internal
that clear?
capsule.
Okay. Okay. So through the posterior limb of internal capsule, it would just come here. Okay. So remember, which artery is responsible for supplying blood to posterior to your internal capsule? Yes.
Is it middle?
Yeah, so the middle meningeal artery moves like that. We have discussed, right? We have a sulcus, that is a lateral sulcus, right? And in between, it would just give small branches to your thalamus as well as your internal capsule, right? And laterally, then it's going to supply the homunculus. Is that clear? We'll be discussing the blood supply. So you have a U-World MCQ. If you have an individual, he have lost both of his sensory responses as well as motor responses, you already know that it's basically infarction of your internal capsule. Which artery is responsible for that? Middle cerebral artery. Small branches of middle cerebral artery. Is that clear?
Yes.
Okay, perfect, right? So what happens that these fibers are going to come, and as they reach pons, right? You have pons, right? And behind pons, you know that we have cerebellum, right? Hello?
Yes.
Or can you guys just tell me what's the function of cerebellum?
It's
Balance,
coordination.
coordination.
Balance. Gate,
Okay.
gate balance, yeah.
Okay, gate balance. Okay, simply let me just tell you coordination of movement. Coordination of movement. You know that cerebellum is basically, it comes in a subconscious brain, right? It's not a conscious mind, it's a subconscious brain, right? So all of the proprioception, like you have certain tracts which are known as spinocerebellar tracts, if you guys remember, right? So you have anterior spinocerebellar tract and posterior spinocerebellar tract, right? So for example, if this is your spinal cord, we discussed that we have a butterfly here, and in the lateral aspect we discussed we have, okay, all of these descending fibers which I'm discussing, they are also going to be present in the lateral portion. We already discussed it yesterday, right? But you have some small tracts that are known as spinocerebellar. It means that these tracts are going to move through the cerebellum, to the cerebellum, right? So you have anterior spinocerebellar and posterior. Anterior spinocerebellar and posterior spinocerebellar, right? So all of these tracts just move into the cerebellum, right? Is that clear? Hello?
Yes, sir.
Yes, sir.
Okay. They move through the cerebellum. And what function is brought by them? We discussed we have muscle spindle, we have Golgi tendon organ. So all of the information from the muscle tendon and Golgi like apparatus is going to ipsilaterally move into cerebellum. Those fibers are ipsilateral. Whatever fibers are coming into your cerebellum, that would be ipsilateral. Remember that. Is that clear? Hello?
Yes, sir.
So if the information from your muscle spindle and from the Golgi tendon organ is coming to cerebellum, so can I say that cerebellum already know the position of your muscles? Can I say that?
Yes.
Yes.
Subconsciously, your cerebellum is aware of the position, of the amount of strength which already a muscle have. Like cerebellum know everything. It knows the position. It knows all of the information of your muscles, right? So, for example, if I want to generate a motor response, so it means that this motor response directly going down into spinal cord, it should communicate with your cerebellum, right? In order to first of all look at what is the current status of your muscles. Can I say that?
Yes.
Hello? Like it makes sense. For example, if I want to initiate a motor response, right? So in order to undergo proper motor response, it means that I should be aware of the current status, right? For example, if I have, let's suppose, if I'm sitting and I want to run, right? So first of all, my body should know that I'm sitting. First of all, I should stand, then I should run. While I'm already, like standing, then I would just run, right? So in both of these situations, the position of your muscles are different. And the action which your motor cortex is going to undergo, that would be different. Is that clear?
Yes, sir.
So in order to initiate a motor response, all of these tracts should be in communication with your cerebellum in order to know the current status, right? So what happens, we have nucleuses which are known as pontine nucleus, right? So these tracts are going to come, they are going to synapse on the pontine nucleus, and from the pontine nucleus, it's going to move into cerebellum. Okay, we have peduncles, right? Which are basically attaching pons with the cerebellum, your medulla with the cerebellum, and your midbrain with the cerebellum, right? So you have inferior peduncles, middle peduncles, and superior peduncles, right? So through the middle peduncles, your pons is basically attached to your cerebellum. Is that clear? So whenever these fibers just synapse on the pontine nucleus, so through the middle peduncles, fibers would go into the cerebellum in order to know the current status of your muscles, right? And then the fibers would just come out and it would just go like that to your spinal cord. Is that clear?
Yes.
Are you guys just getting me?
Yes,
Sir, can you please repeat?
Okay, what should I repeat?
So the cerebellum is gonna be connected to the pons with the help of the pontine nucleus, right?
Yes. Okay. So the idea was, as we already discussed, that cerebellum is already aware of your current status of your muscles. So it means that I want to undergo a motor activity. First of all, I should know the current situation of muscles, that what is the tone, what's the position of muscles. So cerebellum already know that, right? So these fibers would just come in a nucleuses within the pons, which are known as pontine nucleus, right? And from the pontine nucleus, these motor fibers would go into your cerebellum through your middle peduncle, right? And then these fibers would then came out. Once they have information, the current status of the muscles, they would just come out. Is that clear? Hello?
Yes, sir.
Like
And
these
Yes.
they're
fibers are
coming
going to, okay, so you can simply, yes, please.
they are coming out from lower peduncle. They are going to cerebellum through middle peduncle and then coming out via which peduncle?
To same middle peduncle, lower peduncle is attached, it attaches medulla with your cerebellum, right? So they are going to, like exit back through the same peduncle, right? So what happens as these fibers just come out, so 90% of the fibers are then going to decassate. 90% fibers are going to decassate in lower medulla. Is that clear?
Yes.
Okay. And these fibers are going to come on the anterior horn of your spinal cord, and they would innervate the lower motor neurons, and they would generate a response. Is that clear? A motor response. Is that clear?
Yes, sir.
And
Yes.
10% of fibers, if 90% decassate, it means 10% of fiber would just come straight, right?
Yes.
Okay. But these 10% of fibers would decassate at the level of your spinal cord. And these 10% of fibers are responsible for your primitive movement. Primitive, what was your primitive movement?
Axial and shoulder. And those.
Yes, axial and shoulder movement. So can I say that these 10% of the fibers are coming from the supplementary motor cortex?
Yes.
Perfect. This was all about your descending tract. Let me just tell you again, right? Don't worry. So we discussed 30% of the fibers are going to come from primary motor cortex, 30% from both premotor and supplementary motor cortex, 40% from the sensory. They would just come through the posterior limb of internal capsule. They would just go into the pons. And in the pons, they need to be associated with your cerebellum because these fibers should know the current situation of your muscles, right? Hello?
Right,
Okay.
right.
Once they know the current situation of the muscles, they'll just come out in the lower medulla. 90% of them are going to decassate. They'll just move. They'll just innervate the lower motor neurons of your anterior horn. 10% are going to go straight and they would decassate at the level of spinal cord, which are important for your axial skeletal movement. It means they are coming from supplementary motor cortex. That was all about descending tract. Is that clear?
Yes.
Excuse me, sir.
Yes, please.
So, what was the name that you mentioned regarding the what do you say? The fibers that go from the spinal cord to the cerebellum in order to know the current position of the muscles?
Okay, so these nucleuses, those were known as pontine nucleuses.
No, the one on the spinal cord.
The one on the spinal cord?
Yeah,
Which one?
somewhere next to the gray matter.
Somewhere next to the gray matter. Okay, so these were the fibers from supplementary motor cortex and fibers for normal movement on anterior horn. I guess there isn't any special word.
Okay.
Don't be worried if there is there isn't a terminology which is important. If you just know the supplementary motor cortex fibers, they are decassating at the level of spinal cord, important for primitive axial movement, and you have fibers which are decassating at the lower level of medulla. 90% it would innervate the lower motor neuron on anterior horn, and in turn it would generate a motor response. Is that clear? Can anyone just give me summary of this descending tracts? Yes, Dr. Muskan, can you just please give us summary?
Yes, doctor. Okay, I'll try. Okay, so you started from the corticospinal tract, yes, descending tract. So you said
Okay,
the five.
no, start from the motor cortex, like frontal gyrus, post and premotor cortex.
From the motor. You mean from the homunculus?
Yes, just be quick, okay? Everyone have to participate. Yes.
Okay, so you talk about the homunculus. Yes. So you said the homunculus. It is an imaginary picture, okay, which indicates the specific area for specific motor neuron. Okay.
Okay.
Then you said that let's suppose we start this from the Broca's area. Okay. So Broca's area, you talked about it. Responsible for phonation. Like a person, he will speak broken words, but his words will make a sense. Then, if there is like damage in the vernix area, the person, he will speak fluently, but his words will not make any sense. Okay, okay.
Yeah.
Then you talk about the frontal eye field. All right, about the frontal eye field, if there is a defect in the right side, so what will happen? That both eyes, they're gonna look towards the left side, that is on the contralateral side. But if there is a lesion on in the right side, then both the eyes gonna gaze towards the right side. Okay. Okay.
Okay.
Then we talked about the primary motor cortex homunculus. So we said that this primary motor cortex homunculus, we know starting from the toes, ankle, knee, and then the shoulder, wrist, and then the face and the lips, jaw, and etc. All right. So we said it is innervated by three arteries: anterior, middle, and posterior parts. Now you gave example. If, for example, a person is having urinary inconsistence, so which artery will be affected? You said anterior cerebral artery. Okay, then let's suppose a person having a problem in the larynx, okay, or in the muscles of the neck. Then which artery will be affected? So we said it is posterior cerebral artery. Okay.
Posterior or
And
middle cerebral?
oh,
The
sorry,
middle.
I'm sorry. Yes, middle, not posterior. Then
Okay.
we talked about the primary motor cortex. No, then we talked about the descending tract. Okay.
Okay. Okay.
Got-
Wait. Wait. Dr. Abdul Rauf is going to tell us about the descending tracts.
Yes, sir.
Yes, please.
So, sir, you basically explained that the descendant tracts are basically called the corticospinal tracts, and the 30% of the fibers are coming from the primary motor area, and the next 30% are coming from premotor plus the supplementary motor area, and
Okay.
40% of the fibers are basically coming from the sensory cortex.
Okay.
So basically, then you do the diagram, and you basically said that these all fibers, which are basically passing in these tracts as well, are also passing through the internal capsule, especially when we have a movement of both these.
Posterior limb or anterior limb of internal capsule?
I
Posterior.
thought it was
Posterior.
posterior.
Posterior limb. Posterior limb. Which
Yeah.
artery is supplying the internal capsule?
Middle
Uh,
manning.
Middle
Middle
cerebral.
Middle
cerebral.
middle
Okay, you have a UL MCQ on that, right? And if we have, infarction of posterior limb, it means both of the sensory and the motor innervations are going to be
Affected.
lost, right?
Yes,
Perfect.
they will be gone. Yes.
Okay, done.
So the fibers will keep on coming in these levels as they are passing through the internal capsule, posterior limb, and then they come down and they pass toward the pons. And from the pons, the fibers have to pass through the cerebellum if we have to generate a movement, because they coordinate all sorts of movement. And at this level of the pons and cerebellum, we have basically the pontine nucleus, which is basically connecting the pons with the cerebellum.
Okay.
And plus this, there are also peduncles present. I'm not sure about their function. I missed that point.
Peduncles are simple connection between. Okay, we have cerebellum. Cerebellum is connected to medulla via inferior peduncle. They are simply a passage, right? A pillars or a connections. They're simply connections. They
Yes.
connect cerebellum.
Yes, yes,
Okay.
they are connection. And as these fibers they come down, they decussate, and 90% of these will decussate and come at the level of anterior horn and
Okay.
generate motor responses. Whereas 10% of the fibers will not decussate here, and they rather decussate at the spinal cord level, and they basically cause the primitive movements. So we can also describe is that they are coming like from the supplementary cortex area.
Perfect. That's perfect, right? So it was all about tracks. Let's discuss blood supply of brain. So today we'll be discussing blood supply of brain. Tomorrow we are going to discuss the midbrain, the brain stem, the medulla, the pons. Along with that, we'll also be discussing like cranial nerves, right? And today our next and last topic is blood supply of brain. It's very important, and a lot of students are very confused. But believe me, right after this lecture, you would know each and every blood supply of each and every structure in your brain, right? Blood supply. right? Okay, remember, brain have the blood supplies which comes from two different, like arteries, right? So you have the subclavian arteries basically supplies your brain, but your internal carotid also supplies your brain, right? Internal carotid and subclavian arteries supply your brain, blood to your brain. So let's discuss the subclavian one, right? Okay, remember, for example, you have subclavian arteries. We also discussed these blood supply, if you remember, in subclavian steal syndrome, if you guys have attended your CVS lectures, right? So from the subclavian arteries, we have an arteries which are known as vertebral arteries, right? Vertebral arteries are going to arise. Okay, let me just draw the picture clearly. I think, just give me a second. Do you guys remember subclavian steal syndrome? Okay, I'm just drawing the blood supply. Till that, Dr. Muskan is going to tell us what is subclavian steal syndrome.
Yes, doctor. For the subclavian steal syndrome, I think there was something stealing. Going on, and from where to where? I'm sorry, I
Okay,
forgot.
who was stealing what?
There is backward blood movement because of
Okay,
infection in the subclavian artery. So this will decrease the pressure and let the blood go back from the vertebral
okay.
artery. Yeah.
When we have vertebro-basilar insufficiency and things, right?
Yes.
Okay, so let's draw the structure. So for example, we have subclavian artery. Okay, subclavian arteries. From the subclavian arteries, there arises vertebral arteries, right? So these vertebral arteries would just go and they would just combine with one another in cerebello. Okay, where are they going to join? Pontomedullary junction,
At the
right?
pons. Yeah, ponton.
Ponto
Yes.
medullary junction. You guys know that, for example, this is your brain, let's suppose, right? So we have pons, we have medulla, and then we have spinal cord, right? So these arteries would just come like that from the subclavian and they would just join with one another here, like, right, at the ponto medullary junction. This is your ponto medullary junction, like that. Is that clear? Hello?
Yes.
Yes, sir.
Once they combine, they will form a structure which is known as basilar artery. Basilar artery. Is that clear?
Yes, sir.
Yes.
Okay, like here I'm just drawing the small picture, right? So they'll just contribute in formation of basilar artery. But from the vertebral arteries here, once they're just joining with one another, what would they do? They would just give one anterior spinal artery and two posterior spinal arteries. Spinal arteries are also important. For example, you have spinal cord, right? So this is, let's suppose, your okay. So you have anterior spinal arteries which are like moving here. You have a sulcus, right? So in this sulcus, you have anterior spinal artery, right, which is supplying 2/3 of your spinal cord, right?
Yes.
And you have two posterior spinal arteries, one on this side and one on this side. They are branches of your vertebral arteries. Is that clear? So you have one anterior spinal artery and two posterior spinal artery. It's going to supply spinal cord. Anterior spinal artery is going to supply 2/3 of your spinal cord, and posterior spinal artery is going to supply, you have two, so it's going to supply these two portions of the posterior spinal cord, right? This half and this half. Is that clear? Hello?
Yes.
Yes.
Okay. Remember that this and the pressure within this anterior spinal artery is too low, right? It's too low, right? So it's very difficult for the anterior spinal artery to perfuse all of these 2/3. So for that, we have segmental arteries. Like in the cervical region, you have cervical arteries which will just join with the anterior spinal artery and it would help move blood forward, right? Are you guys getting me? Hello?
So, yes, sir.
Okay, so we have cervical arteries, and the thoracic region, the intercostal arteries would just come, it would just join the anterior spinal artery and it would help move the blood within the anterior spinal artery, right? So they are just a kind of pumps which are helping the anterior spinal artery to properly perfuse 2/3 of your spinal cord. Is that clear? While in the lumbar region, these lumbar arteries are going to come and it's going to help the anterior spinal artery properly perfuse the 2/3 of lumbar region of your spinal cord. Is that clear?
Yes.
Okay. But in the thoracic region, you have an artery, a big artery, which is known as artery of Adam Wick, right? Artery of Adam. You can just simply remember artery of Adam, right? Which is coming from your aorta. In the thoracic region, this great artery of Adam is going to help with this process. What was the process? Like a pump. It would just help as a pump in order to properly perfuse your anterior two-thirds of spinal cord. Are you guys just getting me?
Yes.
Great artery of Adam. So you are going to see a UWorld MCQ. For example, if you have an individual, he's having some aortic surgery, and as a result of that, this great great artery of Adam is compromised. So it's obvious that in the thoracic region, you can have infarction of this two-thirds of spinal cord, because now the pump is gone, the helping hand is gone, so it cannot properly perfuse your thoracic region of your spinal cord, that two-thirds. Is that clear?
Yes.
Great
Yes.
artery of Adam. Simple, right? So then what happens as it just like combine, it would just form basilar artery. Basilar artery is going to move forward. It's going to give small pontine branches to pons, but along with that, it's also going to give branches to your cerebellum, right? So you have cerebellum here as well, right?
Yes.
Okay. So to the anterior and inferior, okay, this is the anterior and inferior aspect of your cerebellum, right?
Yes.
Uh,
Yes. Yes.
Okay, so it would just give artery which is going to perfuse the anterior inferior portion of your cerebellum, which is going to be called as AICA, AICA, anterior inferior cerebellar artery. Again, anterior inferior cerebellar artery. In some of the individual, this AICA can arise from the vertebral arteries as well, right?
Yes.
Is that clear? Okay, then it is going to give another artery which is known as pica. What is pica? Posterior inferior cerebellar artery. You have perfused the anterior and inferior aspect. What about the posterior and inferior aspect? So for that we have pica, PICA, posterior inferior cerebellar artery. Is that clear?
Yes.
yes.
And as this basilar artery move forward, it also have to supply the superior aspect of your cerebellum, right?
Yes.
So what's the name of that artery which is supplying the superior?
Superior cerebellar.
Cerebellar artery, right? And in the end, what happens? It would just divide into two branches, which are your posterior cerebral artery, not cerebellar, cerebral. And yesterday we discussed a UWorld MCQ, posterior cerebral artery perfuses your occipital lobe, right?
Yes.
Occipital cortex, which is responsible for your visual activities. So we had an MCQ yesterday, a woman, with confibulations. She have, damage to which artery? Posterior cerebral, right? Which basically comes from the subclavian distribution of your arterial system. Is that clear?
Yes.
Yes.
Okay, let me just give you a quick review, right? It's so simple, right? Subclavian arteries, it would just, okay, you guys can just close your eyes and just think, right? So you have subclavian arteries, it would just give rise to vertebral arteries. Vertebral arteries are going to combine where at the pontomedullary junction. Once they combine, it would just give one anterior spinal artery and two posterior spinal artery. Anterior spinal artery is going to supply the anterior two-thirds of your spinal cord, but the pressure is very less. It needs some helping hands. It needs some pumps, right? So the helping hand in the cervical region is going to be given by cervical arteries. In the thoracic region, is going to be given by great artery of Adam. Yes. And the lumbar region is going to be given by lumbar arteries. So in certain procedures, for example, if the great artery of Adam is damaged, which is directly coming out of your aorta, so what happens? You can have infarction of spinal cord, anterior two-thirds of spinal cord, by the way, right? In your thoracic region, right? Okay. So these vertebrae are going to combine. It's going to move up, giving you basilar artery. Basilar artery, it have to, give arterial supply to inferior portion of your cerebellum. Okay, inferior, anterior, inferior, and posterior, inferior. So for that, we have different arteries, pica and ica. Then it would just move upward. It would just give arterial supply to superior aspect of your cerebellum. That is superior cerebellar arteries. Then it would go further. It would end in posterior cerebral arteries, which is perfusing your occipital cortex, responsible for vision. Is that clear?
Yes.
Any questions? Okay. So let's discuss our arterial supply that comes from internal carotid, right? And we'll be discussing how the circle of Willis is formed. So from the internal carotid, remember that, for example, we have internal carotid on the right and left. So internal carotid is going to enter into your brain and it's going to pass through carotid canal and then through foramen lacerum into the cavernous sinus. You guys already know. Inside the cavernous sinus, did you guys remember you have internal carotid, right?
Yes.
And in close proximity to internal carotid, which nerve do we have there? You have a UR MCQ on that.
Abducing nerve.
Yes, abducent nerve, right?
Yep.
Yes, like you guys can see the cavernous sinus, you have your internal carotid, and near the internal carotid, you have your abducent. What is abducent nerve? Sixth nerve, right? For the lateral rectus, remember? And here you have like different other nerves like cranial nerve 3, 4, and for the vision and everything, right? So it's very important. So for example, if we have aneurysm here in the cavernous sinus, so which nerve is going to be compromised? Yes.
Abducent.
If the abducent
The
nerve
six.
is compromised, so can this guy abduct his eye?
No.
Which muscle function is going to be
Lateral
compromised?
rectus.
Lateral rectus. Perfect. You have a UL answer on that, right? So these internal carotid, again, they are going to move to the carotid canal, through the foramen lacerum. They are going to move into where? Okay, so you have internal carotid, right? Once the internal carotid just come, it's going to give ophthalmic branches, 2 ophthalmic branches, right?
So the cavernous sinus corresponds to which place in this diagram?
In this diagram, once like it moves through the carotid canal to the foramen lacerum, here you have cavernous sinus. Is that clear?
Okay, yeah, thanks.
Okay, so it would just give 2 ophthalmic branches like that. Okay, from here you have 2 ophthalmic branches, and the terminal portion are going to wrap around your brain, giving anterior cerebral artery, as we discussed. Anterior cerebral, for example, if this is your brain, let's suppose, right? For example, this is your brain, right? So what happens that these blood supply is going to move like that, your internal carotid giving some ophthalmic branches, and these terminal portion are going to come like that, right? Wrapping around the surface of your brain, supplying the superior medial aspect of your brain. Is that clear? And what homunculus is present there? We already discussed for the legs, for the urinary bladder, right?
Yes.
Are you guys getting me?
Yeah, this is the interior.
Yes, anterior cerebral, right? So these 2 anterior cerebral arteries, they also have a communicating artery, which is known as anterior communicating artery. They are communicating both of these anterior cerebral arteries, right? So let me just name it as anterior communicating artery. Is that clear?
Yes.
Okay, in the middle here, it would just give middle cerebral arteries, right? So for example, if this is your brain, so you have a sulcus which is known as lateral. Sorry? Hello? So in the brain, you have a sulcus which is known as lateral sulcus. So what am I doing? I'm just opening this lateral sulcus. So the middle cerebral artery is going to move through this lateral sulcus and it will just come out through the lateral aspect. So let me draw a structure of that. So for example, like I'm just opening the lateral sulcus, right? And in order to, see the artery, right? So for example, if I have opened this brain lateral sulcus, so it would appear like that, right? Hello?
Yes.
And
Yes.
right here, the middle cerebral artery is going to come. Okay, this was the whole structure, right? So middle cerebral artery is going to come like that. It's going to supply the internal capsule here. These are some small branches, and it's going to come laterally, which is supplying the lateral aspect of your homunculus, where we have head and neck, face. Remember?
Yes.
Is that clear?
Yes.
Are you guys getting it or not?
Yes.
Yes, sir.
Okay, perfect. So this was all about your and the branches of internal carotid. Okay, let me just repeat it again. So you have your internal carotid. It's going to move through the carotid canal, through a foramen lacerum, In the cavernous sinus, you have a nerve which is known as abducent nerve in close proximity. So for example, if we have an individual and in the cavernous sinus, he have aneurysm of internal carotid, which nerve is going to be compromised? Abducent nerve, perfect. It's going to give two ophthalmic branches, and the distal portion of this internal carotid is going to wrap all around your brain as anterior cerebral arteries, which is going to supply the superior medial aspect of your cerebrum. Is that clear?
Yes.
They are also communicated with one another through anterior communicating artery, right? And here in the middle or in the lateral sulcus, it would just give off a branch which is known as middle cerebral. Like for example, if this is a 3D picture and I'm like moving through here, right? So here you are going to have middle cerebral artery. It's going to come through the lateral sulcus, and laterally it would just give branches to the lateral aspect of your cerebrum, right?
Yes.
Hello? Okay. So we also have communication. Okay, let me just draw the picture. Okay, so for example, we were discussing the vertebral arteries, right? Let's start from vertebral arteries and let's discuss circle of Willis, right? So we discussed that vertebral arteries are going to come like that. They're going to join in the pontocerebral junction. Then they'll just move upward like as a basilar artery, right? It would just give ICA. It would just give pica, right? Hello?
Yes, yes.
Then it would give superior cerebellar arteries, and it would just end as, okay, it would end like that, right? As posterior cerebral artery, right? Then we discussed that we have, okay, so we have internal carotid through carotid canal. It would just move like that, right? In the cavernous sinus, and the terminal branches here, they are going to be your anterior cerebral arteries, right? On the other hand, you guys can see, right? So these are your anterior cerebral arteries, right? And you have a communicating artery between them as well. Is that clear?
Yes.
And it would just give ophthalmic branches like that to the eye. Okay? And here we have middle cerebral arteries moving in the lateral sulcus, right? Okay. Then we have posterior communicating artery as well, which is going to communicate this internal carotid with your posterior cerebral arteries, right? They are basically known as posterior communicating artery. They are communicating the internal carotid system with the vertebral system. Is that clear?
Yes.
Yes.
So you guys can see it have formed a circle, right?
Yeah.
Yes, I got it. Thank you.
It is a circle, right?
Yeah.
So let me just call it as circle of Willis.
Okay.
Is that clear? Circle of Willis is present in subarachnoid space, right? And what's the importance of that? Like you guys can see, circle of Willis connects a lot of arteries with one another, right? So for example, it have a big anastomosis. So for example, if one area is compromised, so the blood can move to the other areas, right? So it's very important for that. An important MCQ point which you guys should know, that you have posterior communicating artery, right? For example, in near the posterior communicating artery, remember it's just above your cranial nerve 3. Remember, right? You have cranial nerve 3. If we have aneurysm, saccular aneurysm of posterior communicating artery, so it would compromise your third cranial nerve. Remember that, right? You have a word MCQ on that. Is that clear?
Yes.
This was all about the blood supply. Hope so you guys enjoyed it and you guys know the blood supply now.
So
Hello?
the basilar artery will end as the posterior.
Sorry?
The basilar artery will end in the brain as two posterior cerebral arteries.
Yes, two posterior cerebral artery. Okay, let's have a quick, I would say, a quick question and answer session, right? So each and everyone have to participate. I'll be starting with Dr. Abdul, right? Can you
Yes.
just please turn on your mic? Okay, just tell me about, the vertebral system, vertebral artery system. How do it arise from where? How it's going to join? What's the branches? Yes.
So like this one which you just explained, the vertebral.
Vertebral. Okay, vertebral arteries, they are going to arise from subclavian. Then what happens?
Yes, sir. So, sir, when they arise from the subclavian. Uh, Basically, they have branches. At the down end, we saw the anterior spinal artery, which was basically supplying the two-third of the spinal cord.
Perfect.
And however, it cannot profuse all of them equally. So there are some other segmental arteries which take up the job. Like in the thoracic region, we have the artery of Adam, and in the cervical region, we have the cervical arteries.
Okay.
Okay, and toward the up end, we basically see that we have basilar artery uh,
Okay.
rising in the upward direction and giving the Ica arteries, which is supplying the inferior portion. Uh,
Anterior, inferior, right?
yes, anterior, inferior cerebellar arteries, and above that we have the posterior inferior cerebellar arteries.
Okay.
There, I don't know which areas that those are supplying.
As the name indicates, posterior inferior cerebral arteries, the posterior segment of cerebellum, posterior inferior segment of cerebellum. It's so
Yeah.
simple. The name is just showing you everything.
Yeah. Yes. Yeah. And after that, we have the superior cerebellar arteries, which are basically supplying the superior portion of the cerebellum.
Okay.
And yes, and
And in
after
the end,
and then, sir, I didn't get.
posterior.
Terminal.
What's the terminal branch of
Posterior
this?
cerebral arteries are the terminal.
Yes, posterior cerebral arteries, right? Which is going to supply your occipital lobe.
Occipital lobe. Okay.
Okay, Dr. Abida, can you just please tell us about the internal carotid? Can you just please tell us the pathway of these blood? Dr. Divanshi. Hello?
Yes, doctor.
Yes, please, can you just tell us something about the internal carotid?
Can I say?
Yes, please, Dr. Satarov, please.
I'm talking. One second. Internal carotid artery, yeah? And
Yes.
internal carotid artery, it's going just, like around the, like brain. And then
Okay.
it's, yeah, and then it first gonna give the, like middle cerebral artery and the anterior cerebral artery.
Okay.
Then two arterial cerebral arteries, they're gonna come and they have, like just the, like connection. And it's communication.
Hmm.
And then it's gonna go through in the front of the lobe, and then supply all the anterior cerebral
Yeah, superior middle aspect, right?
yeah, and superior medial, yeah.
Yes, and the middle is going to come through the lateral sulcus, supplying the lateral portions of your brain,
Yeah.
right? Which we already discussed, the homunculus and everything.
Yeah.
Okay,
and
then we
it's-
have anterior communicating artery
Yeah.
and posterior communicating.
yeah, posterior communicator arteries that's communicate, like with the, how it's called, posterior cerebral artery.
Yes, and it's going to form circle of Willis, right?
Yes.
If we have aneurysm, secular aneurysm of posterior communicating artery, which nerve is going to be compromised?
Yeah, if you have it like before the communication, like the problem gonna be, like in whole, in posterior and in the internal. If you have the after the communication, behind the communication, I mean like posterior communication artery, and the problem gonna be only in the posterior cerebral artery, in mid brain.
Okay,
Hi,
third
this is
cranial nerve, right?
Dr. Ahmad. I'm calling to confirm your appointment for
No.
tomorrow at
And
3:15.
yeah, and the all, like the posterior, they are just the branch of the basilar artery.
3 o'clock. For 3 o'clock.
Okay. Okay, perfect. So this was all about today's lecture. Hope so you guys enjoyed. And tomorrow we'll be discussing the brainstem. Believe me, we are going to make that discussion so easy as we did today. And along with that, we'll be discussing all of the cranial nerves, its function. Then we'll be doing in the end cerebellum, as well as like the remaining basal ganglia, and along with that, the thalamus and hypothalamus. So this discussion is going to take some time. Like we might extend the duration, so don't be worried, because neuroanatomy, whenever I say neuroanatomy, a lot of students are very afraid of that. But believe me, we are going to make this discussion so simple. Thank you so much. Hope so you guys enjoy.
Thank you, Doc.
Thanks,
Thank you.
So much.
So much.
Thank you,
so
Doc.
much.
Stop. Thanks.
Have a good
Thank
one.
you, Doctor.
Yes, we are going to have session on Discord right after 1 hour.
Okay, sir. Thank you.
Thank you. Thank you, sir.